A very warm welcome to all of you joining us from across the region and around the world for this important gathering in conjunction with World Obesity Day 2026. It is truly my honor to serve as chairman and moderator for today's webinar. We are privileged to bring together an exceptional panel of global experts, academic leaders, clinicians, and public health advocates, all united by a shared commitment to addressing one of the most pressing health challenges of our time, obesity. Today, obesity is no longer simply a matter of body weight. It is a complex, chronic disease with profound consequences for individuals, families, and societies. It is closely linked to a wide range of non-communicable diseases, including type 2 diabetes, cardiovascular disease, hypertension, cancer, and other metabolic disorders. These conditions not only affect quality of life, but also place an immense burden on healthcare system worldwide. Across the globe, we are witnessing a deeply concerning trend. More people are living with obesity than ever before. Younger populations are increasingly affected, and the long-term impact on public health and economic sustainability continues to grow. Perhaps most concerning is that obesity often develops gradually and silently, with many individuals unaware of the risk until complications emerge. This is why today's theme, Act Now Against Obesity, Prevention, Technology, and Healthier Futures, is both timely and urgent. Because if we are to reverse this trajectory, awareness alone is no longer enough. We must move decisively from awareness to action. Addressing obesity requires a comprehensive and a collaborative approach. It is not a challenge that healthcare professionals can solve alone. Instead, it demands coordinated efforts from many societies, from sector society, including governments and health and policymakers, healthcare professionals and researchers, technology innovators, educational institutions, community organizations, and most importantly, the public. The role of government is to provide public health policies and food and nutrition regulations. They also need to provide urban planning, active lifestyle, and population-level prevention strategies. While the healthcare system will need to establish early screening and diagnosis, evidence-based treatment, multidisciplinary care, and long-term management. Today's webinar embodies this very spirit of collaboration. We are honored to see leading institutions and organizations coming together from academic universities and international research centers, healthcare alliances, and professional societies. These partnerships send a powerful message. A global health challenge requires global cooperation. One of the most important messages that we must emphasize today is that obesity is preventable. However, prevention is far more complex than simply telling people to eat less and exercise more. Obesity is influenced by a dynamic interaction of biological, behavioral, environmental, and social factors. Urban lifestyles, sedentary work environments, unhealthy food environments, stress, sleep deprivation, and socioeconomic conditions all play a significant role. This means that effective prevention must begin early in life and extend across environments where people live, learn, and work, including families, schools, workplaces, and communities. Education and awareness remain vital, but awareness must be accompanied by supportive environments that make healthier choices easier and more accessible for everyone. Another powerful dimension in today's discussion is the role of technology. Rapid advances in digital health, continuous monitoring systems, artificial intelligence, and personalized medicine are transforming how we detect, monitor, and manage metabolic diseases. Technology now enables us to identify risk factors earlier, monitor metabolic responses in real time, empower individuals with meaningful health insights, support clinicians in delivering more personalized and effective care. In many ways, technology is becoming a bridge between prevention and treatment. However, innovation must always serve a higher purpose, improving patient outcomes and empowering individuals to take greater control of their health. Today, we are privileged to hear from a distinguished group of speakers representing diverse regions and perspectives. They bring valuable insights from clinical practice, academic research, public health policy, technology innovation, and behavioral science. Through their expertise, we will explore the evolving science of obesity, the complex relationship between obesity and diabetes, the role of nutrition and lifestyle interventions, the impact of digital health technologies, and the importance of collaborative healthcare ecosystems. Such dialogue is essential if we are to develop sustainable, evidence-based solutions. Equally important is the need to transform how society understands obesity. For far too long, obesity has been associated with stigma, blame, and misunderstanding. Yet, science clearly tells us that obesity is not simply a matter of personal discipline or willpower. It is a chronic medical condition influenced by genetics, hormonal regulation, environmental factors, and behavioral patterns. By shifting the narrative from blame to understanding, we can encourage individuals to seek help earlier and reduce the stigma that prevents many from accessing care. As we gather today, let us recognize that every sector has a role to play. Healthcare professionals must continue to advocate for evidence-based care. Researchers must deepen our understanding of metabolic disease. Policymakers must support environments that promote healthier living. Technology innovators must design solutions that are accessible and meaningful, and communities must work together to support sustainable lifestyle change. Only through such collective action can we truly make a lasting difference. Before we begin today's session, I would like to leave you with a simple but powerful message. 1, obesity is preventable. 2, early action is possible. And 3, and together we can build healthier futures. Thank you for joining us. And let us begin today's discussion. We have distinguished speakers. And with that, it is my great pleasure to welcome our distinguished speakers and begin this important discussion. Our first speaker today is Dr. Murallitharan Munisamy. It is my pleasure to introduce Dr. Murallitharan Munisamy, Medical Director of the National Cancer Society of Malaysia and a respected Malaysian public health physician, specializing in health systems, public health, and health economics. A Chevening scholar, he completed advanced fellowship training in health policy, planning, and financing at the London School of Hygiene and Tropical Medicine and the London School of Economics. He earned his PhD in public health from Chulalongkorn University and has served in multiple roles, including clinician, clinical epidemiologist, and health system leader, working extensively to improve healthcare access for underserved communities. Dr. Murali will be talking about obesity and chronic disease, the bigger health picture, connects obesity to cancer risk and lifestyle disease. Dr. Murali?
First of all, very good afternoon, good morning, wherever everyone is. Thank you so much for this wonderful opportunity and such an honor to be able to speak to this distinguished audience as well. I am checking on whether I can be heard and my slides are visible.
Yes, doctor, we can see you and your slides.
Okay, full screen, yeah? So this is fine. Okay. First of all, it's a very opportune moment in, I think, the history of chronic disease, non-communicable disease. For the first time, I think people are looking at it's such a big fad and how people have actually embraced obesity as a serious disease. And interestingly, due to how to say no small coincidence, the onset of this entire industry around injectables, GLP-1s, and all these are really transforming the way society is looking at obesity. So I think at this point in time, while it's an exciting kind of area, very interesting for a lot of us in non-communicable disease. Non-communicable disease traditionally is a very boring area. It's not really sexy. You don't get celebrities doing big concerts on it like HIV or something. But obesity has really transformed the entire landscape. So it's when you go to all these high-end cocktail parties and everyone is talking about, are you on which kind of a GLP are you on? So it's a very interesting time. And so while it is this exciting and interesting, it's also very prudent for us healthcare professional working in that space to be able to take a more somber note and kind of keep things grounded, keep things evidence-based, and be able to really provide good outcomes for all our patients and the people that we serve and work with overall. So I'm coming to you this afternoon in the context of cancer. In my day job, I'm the managing director of the National Cancer Society of Malaysia. So please allow me in the next about 15 minutes or so to be able to speak to you about why is this a big problem for us? Because the first question, even my board asked me when we said we wanted to, we were sending them links on this, it's like, why are you all so busy about obesity? What has it got to do with cancer? One word, everything. I'll just, and I'm sure a lot of speakers will cover some of this over this session. So I'm just giving you a very quick, brief overview of the fact that we've got more than 1 million people who are obese. It's becoming a quickly growing problem if it hasn't grown already. Countries like Malaysia have, unfortunately, the dubious honor of being among the most obese populations in Asia, if not in the world. And of course, we've got this huge pressures from our sedentary lifestyles and our nutritional kind of eating habits, which are proving to be poorer than expected. And all these are contributory factors towards if you would say, epidemic, the obesity epidemic, if you will. As I was telling you again, just zeroing down into Malaysia, huge number of overweight and obese individuals. And this is contributing directly, actually not even indirectly anymore, to the growing NCD burden. Now, let's come to cancer and why is obesity such a big problem in cancer, and why cancer civil societies, cancer organizations, the cancer landscape has to actively fight obesity. In cancer, and I'm just stepping away a little bit from the slides to be able to share to this audience, there are some things that we know that are non-modifiable. And non-modifiable factors drive mutation. And there's nothing, I mean, by its very name, things like non-modifiable already, I think, gives a very clear picture on these are things that we can't do much about. However, there are a lot of modifiable risks that lead to cancer. And this, in the game of cancer, it's like a big kind of game of risk management. You try to reduce your risk pertaining to cancer, and that keeps you on the low end of the chance scale that you will pick up a mutation. So in this kind of big picture of modifiable factors, of course, two of which we are very, very aggressively looking at, and traditionally cancer civil societies over the world have played very big roles in disruption and really trying to lead to annihilation of one of the leading modifiable factors of cancer, which is tobacco, smoking. So if you will see, and historically, across from America to Russia to Malaysia, it's always the cancer civil societies that lead the fight against tobacco. And because tobacco is one of those factors that, and tobacco, nicotine, and all its kind of associated friends and family, this leads to so many different cancers, and it's a major driver of mutation. It's a major driver of death, poorer uptake to treatment. So it's a very clear picture. Now, what we're starting to wake up to, ladies and gentlemen, is the fact that obesity is the same. It's a major driver of cancer, and we need to pick up the role of playing active disruption, curbing obesity, and the drivers leading to obesity, especially those that are coming from commercial kind of determinants of health, and really take a leading role in it's like how we play big roles in smoking cessation traditionally. I think cancer civil societies need to take on big roles on weight management, on obesity management, on how we can get our people living with cancer, people who may be at risk for cancer, how do we get them off that kind of risk levels? So now, just allow me to go a little microscopically into this and how obesity on a pathological level leads to cancer. Basically, obesity drives chronic inflammation, and along with hormonal disruption, insulin resistance, all this drives mutation. I'm sure, if, like I said, in the idea of brevity, I've kept my slides very simple. Happy to have like a half an hour, 40-minute separate session on all these different signaling pathways that are disrupted and promoted, leading to essentially driving mutation on a large scale. And the problem with obesity is it's not limited to one part of the body, it's the entire body. So as a result, you start seeing this kind of very mutagenic environment, very rich environment all over across the body. And rightly so, you start seeing a whole lot of cancers which are linked to obesity. So the obvious ones, which are your solid tumors, your breast, colorectal, liver, pancreatic, kidney, endometrial, these are the direct ones that are visible. But even things like meningiomas, multiple myelomas, these are also now increasingly showing very strong evidence linked to cancer. And this is kind of the problem, because the link between obesity and cancer does not stop at only the fact that obesity will increase the likelihood of you getting a mutation and thus the likelihood of you getting cancer. But obese patients on cancer treatment do poorly. They have poorer survival, poorer end outcomes. They even link to difficulty in treatment. So it's how to say, it's across the cancer care continuum, and it gets worse. Patients who are obese, far longer after their cancers are treated, they go into stable disease or remission, continue to have higher rates of recurrence and onset of new cancers linked to obesity. So in short, this thing is as big as a problem it is to cancer as tobacco is, if I could make that really sweeping statement. For example, I'll just zero into one cancer, and you see obesity and breast cancer, fat tissue increases, estrogen, the kind of subsequent hormonal stimulation of tumors. And in cancer patients, people with breast cancer get more aggressive disease compared to other non-obesity driven breast cancer types. Weight control, of course, lowers the risk, as I was telling you, across the entire breast cancer continuum, and prolonged obesity or continued obesity well past the point where the patient goes into stable disease or remission drives recurrence. So it's a major problem. So as I was telling you, on an obese patient, surgery is much more difficult. We're starting to see actually not starting to see, actually now the evidence is becoming more and more mainstream, as in people are waking up to this, that it induces a reduced treatment response, both in terms of chemotherapy, in terms of radiotherapy, and it drives, of course, high recurrence. And on people who with obesity, on cancer treatment, they just cost a lot more as well. So that's another big kind of challenge. So of course, I'm not going to speak to this slide. I've just put it in to kind of show solidarity with every other speaker that's coming out and telling you that, you know, there is kind of a lot of factors driving obesity. But I'm just going to stop with this singular statement for this slide, which is it needs to be a multi-pronged, multi-dimension, multi-stakeholder approach. And only then, we can look at kind of containing obesity, because do not, and again, if I could speak to this, and I'll speak to this right at the end, do not underestimate the kind of industry pressure from commercial determinants of health. There's this whole thing that we're waking up to about commercial determinants of health. Traditionally, we've addressed tobacco, but big food and big industry is a big push. We are about 20 years behind on addressing the impact of that onto our society. Population level solutions. I am a big fan of this statement. The solutions for non-communicable diseases do not lie within the healthcare system. All of your solutions that will transform and kind of disrupt the way that we are managing non-communicable disease now, which, as everyone knows in this session, is just spiraling out of control, is the fact that we continue to look at healthcare solutions, driving only healthcare solutions at non-communicable disease. Obesity is the same thing. We cannot drive this from the healthcare system. It has to be driven outside. Workplace, active transport, school nutrition. These are things that will make a difference 10 years down the line. Sure, manage our patients, give our patients the best care that we can, reduce their risk, manage their disease. But if we want, to bring or downstage this problem, bring about a really true population level solution that will transform our outcomes, these solutions need to be outside the entire healthcare space. And that's where we're increasingly working on. Statistics in Malaysia, not going to speak to it. I'm sure I see enough eminent speakers in Malaysia who will speak to this. But let's also talk about money, because really, increasingly, I think a lot of clinicians, healthcare systems people, policymakers, we're waking up to the fact that despite you having excellent clinical trial data, 5-year data, 10-year data, 200-year data, nobody cares except for the bottom line. The policymaker is, at the end of the day, only very interested in how is this going to affect me in terms of ringgit and cent. And again, this is a story where I feel that we're not telling enough. We talk about productivity losses. We talk about long-term treatment costs. We talk about chronic disease pressure, economic burdens on families, higher healthcare spending overall. But what seems to still be the disconnect, like I said, this is the impact of healthonomics is a huge one. I write a column on the edge on this and kind of marrying health and economics, and it's a good kind of perspective to look at the world. And what we've been unable to do is the fact that we are unable to still convince our policymakers that prevention, far cheaper, ultimately is a huge saver of every single expenditure matrix that we've looked at across any single country. We have been unable to reconcile this very basic fact. We need to be able to do it better. And obesity is a classic example of that. We've got really good medications now which have come into the field to really transform the fact that, you know, an individual who are now basically go to almost low risk, normal risk, with the kind of treatment modalities that we can put them on. But the fact is, we continue to struggle with health systems. We have to beg, borrow, steal. What is this? Black market shipping through pirates to get drugs to our patients. It's a joke. It's a joke. And of course, I come back to what can we do, because it's pretty for us to kind of speak into a webinar and then say, you know, all you fellas, you must do something for society. We must reduce obesity. And then we end this webinar and then everybody claps. And then, you know, the Cancer Society feels like it's done its job. Now, I'm here to tell you that, no, we are an important partner in this struggle. We want to do this as much as all of y'all working in obesity want to do it, simply because we are selfish. This is something which is impacting our patients in a big way. So one is community outreach. For the past few years, we've already done this onto all our community outreaches. We start to have every single obesity parameter captured, start to provide counseling, start to provide promotion in terms of screening for obesity. And we've started obesity, lifestyle risk reduction and obesity clinics running in all our centers all across the country, working together with endocrinologists, diabetologists, family medicine physicians. So I'm here to say, ladies and gentlemen, that we are not just putting our mouth, we are putting our money where our mouth is. And we are here to work alongside you all to actually drive the, how to say, turn and really turn the tide. We need to downscale obesity. And because upstream, we're the ones ending up managing the poorer outcomes, which is cancer. So wherever, whatever role that the cancer civil societies across the world can play, I think we need to, and we need to be able to do it together. Last, let me just end with this, which is obesity is a preventable cancer risk. Reducing obesity reduces the cancer burden, and prevention of obesity ultimately is one of the strongest cancer control strategies that we can do, which is why we are invested. We will continue to be invested, and we are here to help and work together. I'm going to stop right here.
Okay, thank you very much, Dr. Murali. We've got one question here for you, Dr. Murali.
Yes,
of the solutions shown, which one is the most effective for reversing obesity in Asian patients specifically?
Actually, I thank you, Prof. And on an individual level, like I said, I'm not here to kind of speak on an individual clinical management level, but on a population level or on a community level, I think you need to go about this across every single matrix that you can. So you need to see work in the schools so that we can start addressing obesity at the childhood, at the teenage level. We need to start addressing commercial nutritional content. So at the kind of medium end, how can we cut down the amount of food that's being served? How can we make people be able to gainfully buy healthy food choices that will then reduce their intake? And then we need to have policies that can drive community level interventions that can promote obesity control. And then only we can look at putting up services to make sure people in the community are not getting stigmatized. They are coming because, I mean, how to say, until today, it is very sad and similar. Another similarity between smoking and obesity is people always put out this narrative that it's your fault. Sure it is, but now increasingly it's not, because we're realizing there's so many different factors that drive obesity, not least of which is your socioeconomic status. And so this is a genuine disease in which people need help. And the kind of societal transformation needs to come from many different components. I will stop there. Thanks, Paul.
Okay, thank you, Dr. Murali. Okay, I think there are no more questions there. Then we go on to the next speaker. It's my pleasure to introduce the next speaker, Professor Julia Mada, full professor of diabetes technology at the Medical University of Graz and deputy head of its diabetes outpatient clinic. Professor Mada leads the diabetes technology research unit with research focusing on insulin pump therapy, continuous glucose monitoring, automated insulin delivery systems, and decision support technologies in diabetes care. She has authored more than 190 peer-reviewed scientific papers, received multiple national awards, and serves on the executive board of the European Association for the Study of Diabetes, where she also chairs the Training and Education Committee. Professor Julia, I invite you to deliver your talk now.
First technology problem solved. So I can't see you now, I just see my slides. So if anything happens, please just say something because I'm just now on my slides. I'm talking about transforming obesity and metabolic health, technology, potential early interventions, and healthier food futures. As you can see, I'm from the Medical University of Graz, and that's our beautiful university building, where we also have our diabetes and obesity clinic in. So these are my disclosures. And obesity is raising across the globe, and specifically we see next to the US that we see a big rise in both China and India. So they rank second and third when it comes to obesity. And the annual growth rate, specifically in the Southeast Asian population, is expected to be around 4%. So when we then think of what is obesity associated with, so we definitely have a strong association with many other diseases. So they can be out of the gastrointestinal system. It can be, as we heard from our previous speaker, related to cancer. It can be related to cardiovascular disease. So whatever we do, it's not about just treating a problem of aesthetics, as many of our peers sometimes try to let us think and downplay the relevance of treatment of obesity, but it's a genuine disease with a lot of complications and with a lot of associations with other diseases. And if we look for very strong associations, we do see, and those are the circles in the dark blue, specifically on cardiovascular health, on diabetes, on heart failure. We do have very, very strong associations between obesity and these conditions. The causes are complex, so it can be hormonal imbalance, it can be socioeconomic factors and environmental factors. And I just had the honor of chairing our national obesity webinar for people living with obesity or people interested in the condition, and where we discussed what people can do on a daily level, and already every minor steps count. So we should really let people know that using variables to hopefully modify behavior will be quite helpful. So for example, if you just start off, of course that's not the final treatment goal, but start off telling people, okay, step out of your bus, step out of your metro, maybe one stop ahead of your final destination, gives you some extra steps that could be helpful. Then of course it's also psychological. It can be influenced largely with stress, with eating disorders, moods and anxiety. Then of course endocrine disruptors and the microbiome are relevant. Medications that people might be on, such as steroids and antipsychotics, might lead to weight gain. Or if we think of the interplay between diabetes and obesity, insulin and insulin overdosing can cause it. And unfortunately, a large proportion is also genetically driven. So that's the part we can't really influence. And interestingly, I was also in another meeting just 2 days ago, and that was about sleep and its really cross-sectional effects on health. And one of them, of course, is also obesity. So I know people, especially in Asian countries, are in these days very industrious and very productive, and tend to kind of see maybe sleep as not the most relevant aspect of life. But when we consider how bad sleep and poor quality of sleep and little amount of sleep can negatively affect body weight, we should potentially reconsider that also sleep is important. And the EU has considered it now as the third pillar of health. Next to physical and psychological health, sleep is now part of the third pillar of health in Europe. And what all of us that have been potentially on diets and treatment regimes for obesity have seen, weight loss is not easy to manage. And then if we manage, it's not easy to maintain, because diet and exercise alone really are not always effective, and people might regain their weight. Because during weight loss, we increase activity, we try to reduce calorie intake, but the body fights back, because we have kind of a metabolic set point that the body always wants to kind of achieve the highest body weight they ever had. So that then would reduce our metabolism, would drive up our hunger hormones, and reduce our fullness hormones. So it's really important to keep that struggle active and keep fighting for maintaining your weight after having achieved weight loss. If we think again, especially in the interplay between diabetes and obesity, what are the relevant aspects that we need to tackle? It's not, again, about high body weight or high blood glucose. It's really a relevant determinant of health, where we can have an interplay with the microvascular, the macrovascular system, where we have an increased rate of cardiovascular disease. We have an increased rate still of retinopathy, neuropathy, and nephropathy that are still causes of later life complications such as amputations, vision loss, and causing still dialysis. So treating diabetes, treating obesity early and effectively will in the long run save costs for our healthcare systems. But, and we've seen a lot of those devices trying to also flood the European market when it comes to non-invasive glucose monitoring, and maybe some of your people with obesity might be wearing those smart watches. In the end, you need to interpret the data, so be very, very cautious because, for example, there was a test from our friend Guido Freckmann in Germany where he equipped a banana with 2 different monitors. Not only did they show different results and quite largely different results, but also fluctuations in the glucose content of that banana. So many of those devices just show us fake information. And also the FDA gave out a warning when it comes to glucose monitoring. Please use relevant and tested devices and don't rely on some over-the-counter, quite expensive gadgets. And of course, people potentially might want to invest in a one-time investment, 40 euros for a smartwatch that measures glucose compared to a CGM where you need to buy it for 40 euros a sensor, but really inform them that that's not the valid way forward. What other challenges do we have? Of course, when it comes to diabetes, the goals, we might need to better understand the insulin therapy, and people in many cases miss time or miss the insulin dose. Otherwise, they have a wrong insulin dose and over or underdose, or there is a misalignment between the timing of the meal and the timing of the dose. And all of that can really lead to an suboptimal glucose control. So another type of technology that is around that helps us to keep track of the timing, the dose, and the information if an insulin dose was injected at all. And those connected pens in the long run will help us to improve not only glucose control, but also, and importantly, improve satisfaction of people living with diabetes because they feel more self-competent in their diabetes management. And when we look into digital behavior-based interventions, there is a new word coming out, that's the digiceutical, and that's a combination of a pharmaceutical that may enhance its value by addressing the pharmaceutical effect with some behavioral aspects, and the raw therapeutic treatment together with behavioral and therapeutic treatment can really have improved outcome over just administering the drug. And last part of my talk, I just shortly want to also show you some real-world data across Austria, Germany, and Switzerland. This year, I hope we will also get, for the first time, data out of India. So I think the data collection has just been started. And it was given those questions to people living with the condition. This is to the right-hand side, and also to their healthcare providers. Of course, one may take it with a grain of salt, saying that people who are responding to those surveys are probably more interested in technology than others, but still some important data. So we see that in all of our 3 countries here, we have a relatively good penetration of CGM also in type 2 diabetes. Insulin pump therapy in type 2 diabetes is higher in Austria compared to the other countries in type 2 diabetes. But what we also see, there is some uptake of AID in type 2 diabetes, and that is not because people in the other countries don't want to go for it, but reimbursement issues. Very interested in if there is a change in the 2026 data that will be coming out hopefully next month. But yeah, let's see for that. The smart pen use, again in type 2 diabetes, has also taken up a little bit in the last year. And there's also a consensus paper that will be discussing the difference between smart pen and connected pen. And I think personally, a smart pen is only then a smart pen if it gives you some advice and not only tracks your data of delivery of the substance. So there might be some new definition coming out in the future. So looking into the people who use different types of technology, and that is mostly type 2 diabetes. So we do see that a large number of people already on insulin, on basal insulin, and also on oral agents is using CGM if provided by the healthcare system. And here Swiss people are in the lead because their healthcare system provides also payment of CGMs in people with type 2 diabetes without insulin therapy. The attitudes towards digitization, and that comes again reported from the healthcare providers, is quite positive all across the country. So I think all of us have understood that digitization will help us to improve our care. There is a lot of people again feeling, and that's the healthcare professionals, how they see the people living with type 2 diabetes struggle with technology. And they say there is, in the majority of people, and that's across different times, so 2021 to 2024, a reduction in diabetes-related burdens when people are using technology. Maybe some new burdens might arise, and those burdens can be technical burdens, overload, lack of trust, and some feeling of dependency on the technology. When people are asking about the relevance of technology, again, CGM is in the lead, shortly followed by AID systems. And the future trends people assumed will be in the direction of smart insulins, fully closed loop, and stem cells and immunotherapy. But what we also need to consider when we talk about a chronic condition, it's not about only technology or medication, and I think you will hear about that more in the later course of the program. It's also about the communication and motivation to avoid stigmatization and really to empower the person living with a chronic metabolic condition to become his own specialist. But you, of course, should keep your knowledge up, because what we sometimes see in younger doctors, when they see patients, they want to be super smart. And then the patient, when he comes next time to a more senior doctor, says, well, the last visit was for nothing because that young doctor did not have any knowledge about my condition. So it's, of course, important that they are self-empowered, but still we also need to be able to train them well. So in the end, it comes to very positive support together with all the tools and our motivation of the people living with chronic metabolic condition. Thank you very much.
Okay, thank you. Thank you, Prof. Julia. I think we've got a few questions here. First one is, since missing insulin doses is so common, do connected smart pens actually help patients to feel more confident in managing their own care?
So what we have seen, and I think that's a very positive aspect, that they for sure can better understand what a missed dose is doing. But only pens that really have a reminding function will help them to adjust their therapy to missed doses or underdosed happenings. And what we've also seen, especially in early stages of diabetes, when they are very unsecure about the therapy, if that connected pen or smart pen tells them a dose suggestion, people are quite accepting these suggestions, and they are very thankful for that.
Okay. The next question is CGM approved to use in type 1 diabetes below 5 years old? And is it approved for use in hospitalized patients?
That's a very good question. So below 5 years of age, it depends on the system. The majority is, some of them are above the age of 1. Age of 5, it's the majority would still be covered. And still, and that's what I have to admit, most of us are using them, even if not licensed, telling the patient's parents that it's off license in that age group. For the hospital, it's a little bit of a different ball game, and I think there will be also a statement from the Diabetes Technology Network coming out of the UK, where in some situations they will allow, even if the companies at present would not formally have it approved because of the interfering substances, low blood pressure, and all of that, that might affect the accuracy of the devices.
Okay, great. Thank you very much, Prof. Julia. Okay, so we go on to the next speaker now. Our next speaker is Dr. Jothydev Kesavadev. Dr. Jothydev Kesavadev is the chairman of Jothydev's Diabetes Research Center in Kerala and national president of the Diabetes Technology Trust of India, a member of the Central Executive Committee of the Research Society for the Study of Diabetes in India. He's also editor-in-chief of the International Journal of Diabetes and Technology. With more than 300 scientific publications and pioneering work in technology-enabled and telemedicine-based diabetes care, he has played a major role in advancing accessible diabetes management globally. Dr. Jothydev Kesavadev, I'd like to invite you to present your lecture now. Okay.
Hello, dear friends. I am Dr. Jothydev Kesavadev from Trivandrum in Kerala, from the south of India. Thanks to my dear friend Satyaprakash Tiwari for this opportunity to partner with BUZUD. I am the Managing Director of Jothythev's Diabetes and Research Centers in Kerala. So let me start sharing my slides. Mr. Satyaprakash has given me a very, very interesting title to my lecture: Obesity, Diabetes and Technology and the Future of Metabolic Management. I don't have anything to disclose pertaining to this specific lecture. Let me start with a case scenario. Most of us are clinicians, and daily we encounter with our patients. And this is one story of a girl, and she met me alone, without any bystander. A 25-year-old girl, unmarried. She's overweight since childhood with a BMI of 37.6, and she's currently on 3 antipsychotics. And she now has realized that obesity could be the reason for her anxiety, depression, insomnia, and so many associated factors. She said, "Doctor, I used to be a normal person. I think I am going through the phenomenon called body dysmorphia." She has read about it. She is not even close to her parents, and that is one of the reasons why she came alone to meet me. I don't even have a boyfriend. And as a team, we spent more than 45 minutes with her. And she was so comfortable to discuss more about obesity. She said, "I am a learned person and you can go ahead with the discussion because I am now willing for getting treated because I have gone through diet, I have gone through exercise, I have gone through multiple online platforms where I have paid lakhs of rupees but with no benefit at all." And we started discussing ABCD, adiposity-based chronic disease, as described by the ACE, and the Obesity Medical Association and the multiple scientific bodies defining obesity as a chronic disease. I told her it could be a relapsing disease. But the good news now is, though it is multifactorial, and there could be more than 30 to 40% contribution from the genetics, but still, currently it is a treatable disease. And if you go by the American Heart Association's cardiovascular kidney metabolic syndrome, there will only be very young people currently in stage 0. And most of us are in stage 1, and many have reached stage 2 and even advanced stages of this syndrome. Very unfortunate scenario. And we discussed about the dysfunctional distribution of fat. We discussed about ectopic fat deposition in the liver, in the kidney, in the pancreas. And she was very comfortable listening to us. And we discussed about the body composition. And this is something which is a basic in our medical school syllabus. You have the fat, and again divided into non-essential and essential fat. Essential fat is the fat which is there in the major organs, even in the brain. And then you have the organs and the water. And the lean mass will constitute the skeletal muscle along with water and the organs. And the skeletal muscle mass is exclusively of skeletal muscle. And then you have the fat-free mass, which is everything in the body excluding the fat. We discussed her body composition analysis done in our hospital. I told her, you have around 32 kilogram excess body weight, and that is fat. That is fat, and we need to somehow get rid of this fat. And we discussed about the skeletal muscle mass, the percentage body fat, and so on. I told her, don't be scared, but if you go through the new definition as per the India Obesity Commission, and this is headed by Dr. Anu Mishra and the team where we were also members, the revised definition is slightly alarming. Even 23 and above is now considered obesity. And stage 2 of obesity will be a BMI of 23 and above with a raised waist circumference or a waist height ratio, along with obesity associated limitations or comorbidities. So most of us are going to be obese, and it is a dream for us to be fit. Of course, we can have a higher BMI, but if the contribution is from the skeletal mass, it is fine. However, obesity is associated with multiple complications, and some of them are having a very, very strong association. That is the reason why obesity is now considered as a disease entity, and obesity is now recommended as a disease to be treated. If you look at those areas where there is a strong association, it is not only diabetes, it is not only myocardial infarction or a kidney failure, it also includes MESL, it also includes multiple difficult to treat cancers such as cancer of the pancreas, which is phenomenal increase by more than 30% in the recent years, colorectal cancers, bladder cancer, cancer of the breast, and so on. And invariably, this is a very, very old publication. In Lancet in 2009, we knew that life expectancy gets reduced when BMI increases. With a BMI of 35 to 40, there is only 60% chance of reaching the age of 70 years. So policy changes to attain the highest possible level of health and well-being. And these are the recommendations of a paper which is recently published by our team addressing the obesity burden in India and the requirement for policy changes to attain the highest possible level of health, to change the narrative that obesity is a complex chronic disease, moving from a disease management to a health-focused approach, invest in healthcare systems and the capacity to improve obesity management and prevention, initiate, augment, and scale the support given by the healthcare system for people living with obesity. And we also discuss in the same paper, these are some of the prominent newspapers from India, where we have discussed about not even the prevention of obesity, even the primordial prevention of obesity. So what happens? Obesity is a key driver of metabolic diseases. And this is because of the ongoing inflammation. Metabolic stress, there is a systemic inflammation, and this results in disease in the arteries, in the liver, in the pancreas, and ultimately resulting in mortality. I discussed with her on the 4 M's of obesity. And this is something we can even discuss among children in schools and colleges. Mental, mechanical, metabolic, and monetary. Very simple steps. Mental, including mood, depression, anxiety, sleep, metabolic, including type 2 diabetes, hyperinsulinemia, hypertension. And that is where we are discussing the obesity-related malignancies, mechanical, GERD, extremely common, obstructive sleep apnea, headache, plantar fascia, monetary. The cost which is involved in the treatment of obesity-related illnesses, which can be even more than 270 illnesses. And many people argue that I can treat obesity with diet and exercise. And the girl sitting in front of me, she has also tried it multiple times, and they looked at a clinical trial where they were comparing intensive lifestyle intervention against a standard treatment. Of course, in the intensive arm, there was a significant change in the body weight. There were improvements in the glucose, improvements in the blood pressure, but over time, what have you observed? Not only the weight was regaining, but if you look at the outcomes of the Lucas trial, the trial was stopped. It didn't go for 13 years, it went only for 9.6 years because the event rates, the cardiovascular events were the same in both arms. Intensive lifestyle intervention focusing on weight loss did not reduce the rate of cardiovascular events in overweight or obese adults with type 2 diabetes. So lifestyle interventions by itself may reduce the body weight temporarily, but it cannot reduce the cardiovascular events. And this is a lesson, a tough lesson that we have learned over the years. And with lifestyle interventions, we may reduce the body weight maybe by around 2.6%. That is the average weight loss which you can expect. And with pharmacotherapy, now you can aim at a weight loss of more than 15 or even 20%. And that too with multiple metabolic benefits, replacing even the need of metabolic surgeries in the majority. And what are the updates? If you look at the drivers, biological, genetic, epigenetic factors, many pathways can lead to obesity. It is a complex interplay of multiple factors. And weight loss of even 5% will have phenomenal benefits. If we can lose weight by 15 to 20%, it can result in remission of diabetes in overweight and obese people. Even hepatic steatosis can go for a 100% regression. And this has been already proven in the randomized clinical trials. So significant weight loss, there are health benefits and improvement in the quality of life. Obesity, very similar to diabetes, will require technologies. So that is the modern day learning. You require the aid of technologies to help achieve your goals and to help achieve your dreams. And these are the wearable technologies defined as a portable electronic device, one as a private accessory. It can be a watch. It can be integrated into your clothes. It can be a temporary phenomenon. There are smart scales. There are, and these are the connected ecosystems. You have the sensors which can measure your sleep. A short sleep duration of less than 6 hours or a long sleep duration of more than 8 hours. It has got a U-shaped association. And this is linked to a higher BMI and obesity. So the adequate sleep duration will be 6 to 8 hours, easily now measured with your smartwatch. And Apple, of course, they were the innovators. You can very reliably and accurately track your sleep. And this is one of my YouTube videos. I have 2 channels where I have discussed about the multitude of benefits of an Apple Watch, a doctor on your wrist. I would modify it as a hospital on your wrist. And this has been our journey over the years, launching a continuous glucose monitoring device way back in 2004, and that was CDMS Gold from Medtronic. And currently, the landscape is now expanding. We have BUZUD, continuous glucose monitoring, and this is relatively inexpensive, affordable, highly reliable, no need of an NFC-enabled phone. It works even with a Bluetooth connected smartphone. And over the years, we have generated hundreds of publications related to continuous glucose monitoring. And these are multiple publications from India. And this is in International Journal of Diabetes and Technology. CGM is currently recommended not only in diabetes management, but also in weight management, for behavioral changes, for motivation, for personalized coaching. And this is one FDA-cleared device, Stilo from Dexcom, along with an AI-powered mobile app. And this is FDA-cleared for use in obese individuals. The Signo system as the first ever CGM cleared specifically for weight loss and metabolic wellness. And this is even in the absence of diabetes. This is a recent publication from our team, optimizing the glucose monitoring technologies, how we can overcome the currently prevailing challenges in India in adopting continuous glucose monitoring. And in this paper, we have also discussed the possible future solutions. For example, alarm fatigue, poor adherence to the big data, over to the minimal systems. And this is the journey with insulin pumps and automated insulin delivery devices in India, starting from 2004. The 2022 launch of an advanced hybrid closed-loop systems, again, where the dreams are becoming a reality, even in type 1 diabetes, reaching TR goals of more than 80%. No wonder in the clinical trials. Now, sleep is also a primary objective. So sleep is what the patient measures. The physicians like us are bothered about time in range and hemoglobin A1C, but for the patient, it is uninterrupted sleep during the night. And the newer systems, they are automated insulin delivery devices. Thanks to the innovations with continuous glucose monitoring devices, it is now a reality. A 69-year-old with type 2 diabetes of 15 years. And this is our electronic medical record, and this is the diabetes tele-management system. 24/7 availability of a multidisciplinary team. Persons consistently maintaining near normal glucose levels, not developing micro or macrovascular complications of diabetes. With personalized care, personalized diabetes education. And this system has been in existence since 1997. And we have generated multiple publications on its robustness. And this is a 15-year-old retrospective analysis addressing 5 major domains where the telemedicine-based diabetes management is superior when compared to conventional management of diabetes. And this is a BUZUD platform, the AI-powered connected ecosystem, comprising of an AI food analyzer, the health chat 24/7, personalized health guidance and clinical decision support, medical report and prescription recognition, intelligent document analysis for comprehensive health, and so on. So this is currently located in Singapore, and I love this system. The connected ecosystem, connecting the continuous glucose monitoring system, the weighing scale, the blood pressure apparatus, enabling continuous surveillance and yearly risk detection. That's the significance. Supporting data-driven clinical decision-making where the doctor is working along with the team. So it is not only for the public. Even the doctors are comfortable, educate and coach with simple, clear messages, identifying the risk of somebody who is developing a chronic kidney disease or a chronic liver disease, or somebody who is having recurrent episodes of hypoglycemia, working as a team for sustained outcomes, better outcomes. And this is the future. The future is already here with the patient in the center. And this is the virtual, the digital diabetes centers, the clinics connected to multiple sensors, reminders for visiting the hospital, for the labs, for the vaccinations, and so on. So in conclusion, obesity is not a personal failure. I have discussed about multiple technologies in obesity and diabetes. And all these technologies are definitely not for all your patients. Smart use of available technologies can completely transform the outcomes. So here I stop. Thank you. Thank you very much for this opportunity.
Okay, thank you very much. That was Dr. Jothydev Kesavadev. Unfortunately, we do not take questions for this talk, as that was just now a recorded session and not a live session. So I think we go on to the third speaker, the fourth speaker now, Dr. Amit Gupta. Dr. Amit Gupta is the Executive Director of the Global Metabolic Health Alliance and Chair of the International Diabetes Federation School of Diabetes and Education Committee. He holds several international leadership roles, including Secretary of the Global Advisory Group and Chair-elect of the Public Health and Epidemiology Interest Group at the American Diabetes Association. Dr. Gupta also serves as the Medical Director of the Center for Diabetes Care in Greater Noida and Adjunct Professor at Manipal Academy of Higher Education, and contributes extensively to diabetes research, education, and global policy initiatives. Dr. Gupta will be talking about preventing obesity before it begins, early life, schools, and digital behavior. Dr. Gupta?
Thank you, Professor Ismail, for this very warm introduction. And I'm grateful to the Malaysian Cancer Society and the Mr. Tiwari and all the organizations who have asked me to present at this very prestigious platform. So shall I be sharing my slides, or will it be done from the your side? May I ask the AV team? Are you able to?
Can share?
Okay. Are you sharing from your end?
We can share from our end, or would you be comfortable to share?
Let me just do this.
Right.
Are you able to see my presentation now?
Yes. Could
Yes,
you?
right.
Yeah, and then you play from the start. Yeah.
Yeah.
Right.
Okay. So once again, thank you for the warm introduction. And I think this is a very, very important conversation on the occasion of the World Obesity Day. And in fact, a lot of people, they say that it is a obesity week, and some of the organization, they say it is an obesity awareness month as well. So I think we continue a month-long conversation on different platforms, and we talk about the obesity. And today I'm going to talk about this very, very important subject, which is how to prevent obesity before it begins. And can we do something in the early life, school, and how the digital behavior can help us in addressing all these issues. Once again, I'm thankful to the National Cancer Society Malaysia, the BUZUD, MetaMed, our partner organization. It is a proud moment for me to represent Global Metabolic Health Alliance. And good to see Dr. Jothydev, Dr. Ismail, Dr. Julia, and other esteemed speakers on this platform. So let us first look at the Global Obesity Challenge. I think all of you have already discussed various aspects, but just to touch base, the number of the people living with obesity is growing, and it is not just the adulthood obesity, it is also the childhood obesity. So children, they are becoming obese, and this is actually fueling a lot of complications which come later in the life. So it is also, the research has shown that if you have earlier onset of the obesity, then it is a strong predictor of adulthood obesity as well as the metabolic diseases which come in the future life. So one of the most important aspect is that if we want to address the prevention, then it must begin before the metabolic diseases develop. So we have to address the metabolism at a much, much higher level upstream, not when they become manifest in the form of diabetes, hypertension, obesity. So if we can address this, we can prevent a lot of the metabolic complications, and we can have a good metabolic health. What is a good metabolic health? You have a good glucose levels, you have good blood pressure, your lipid profile is normal, you are having a good quality of life, you are physically active, you are having good well-being. So this means what prevention can achieve. But what if we miss the bus? What happens is that we develop risk like type 2 diabetes, cardiovascular disease, fatty liver, and there are many cancers which we discussed in the previous presentation. Now we have to think that why early life matters and why the prevention should begin early. So risk of obesity begins before birth, and it increases during early childhood. So there is an environment which is the prenatal environment, then there is the infancy, then the early childhood and adolescence. So you can look at all the stages. So how does the prenatal environment? So if maternal obesity is there, then probably it also becomes a risk factor for the future development of the obesity in the childhood. Again, if a lady develops gestational diabetes mellitus, then this is the prenatal environment which can actually decide the development of the childhood obesity. Then infancy, what are the feeding patterns which are being adopted during the infancy? This can also this matters a lot, because now conventionally it is mentioned that we should promote the breastfeeding, and the breast milk is the healthiest food for the infant. But we know that because of many reasons, the infants, they are fed on the infant formula milk, and the different preparations are there which are already being used. So infancy again determines. Then the early childhood, what are the nutrition patterns in the early childhood? It is very, very important because whether the child is consuming healthy food, consuming more fruits, vegetables, or towards more of the ultra processed foods and all, this shapes us the nutrition for the life. Sleep pattern is very, very important because this is also the early childhood and the adolescence. Because when a child advances towards the adolescence, there is a lot of peer pressure, there's a lot of pressure from the academics, there is a lot of pressure to perform. Often this is the age where we see the patterns of the sleep, they changes, the children, they stay awake late night, their consumption of the caffeine and the other stimulants, it increases over a period of time, stress level increases. So this is the time which, and this is again the time where the physical activity takes a hit. So during the childhood, even the children, they are still active, but during the adolescence, because of the this academic pressure and a lot of the other changes which a child is going through, adolescent is going through, the physical activity usually takes a backseat. So children with obesity they are 5 times more likely to remain obese in the adulthood. So this is why the early life matters. If you look at the developmental origin of the health and disease, the developmental origin of the health and disease concept explains how early exposures affect lifelong metabolic health. So we discussed the different parameters, that prenatal environment, it is the early life, then we have infancy, adolescence, sleep. So during this period, the metabolic programming is taking place. It is the metabolic programming. So it determines the insulin resistance. It also addresses the appetite regulation, the fat distribution, and the energy metabolism. So all this programming, which you calls metabolic programming, happens early in the life, and we at the Global Metabolic Health Alliance are trying to address this issue of the metabolism at a much earlier stage. Thus, intervening early has lifelong impact, and there are many studies which have shown that. Why now? Let us come to the schools. Why do I believe that the schools are the most powerful prevention platform? Globally, the schools reach millions of children daily, and there is a very structured education which is given to the children over a period of 12 years to 12 to 14 years. And I think this is the best opportunity for any government, any policymaker, any organization to address the growing burden of the metabolic diseases right at the school. How we can do that? We can think of the nutrition education. I think nutrition education, though it is given informally, but I think it is a very, very important subject, and it should be continued throughout the school education in a structured platform way, so that the children, they are able to have a good knowledge of the nutrition, good understanding of the nutrition. Healthy school meals. Why healthy school meals? Because what is available in the school environment also have a impact on our food choices which we make. For example, if a school is having access to the ultra processed foods, if the school is having an access to the very not so kind of healthy food which you say, then probably this will decide the future nutrition pattern of a child. So healthy school meals are very, very important. Recently, WHO has given a guideline that how to provide a healthy food environment in the school, and I think this is a very, very important document. Physical activity programs. All the children, they must be encouraged to engage in physical activity programs, maybe any sports. Most of the schools are doing it, but I think to ensure that they continue it during not only the early period of the school life, but also during the senior schools and during the adolescence phase of the life also. Limiting access to the ultra processed foods and informing children about the harmful effects of the ultra processed foods, how to read the food labels, how to identify which food is good for their health, which food is not good for health. I think this is very, very important. And providing health literacy all through the school education is again very, very important. So evidence, it shows that school interventions can reduce BMI gain and the obesity risk. Now let me talk about the digital environment. So when we talk about the digital environment, so digital environment has the disadvantage as well as the advantages as well. It is a known fact that most of the children, they are spending almost 6 to 8 hours daily in digital environment, and this may be because of various reasons. Sometimes they have to do school assignments, sometimes they have to do some projects, sometimes it is for the purpose of the entertainment, sometimes it is for the purpose of the ordering some food or looking or searching something. So on an average, 6 to 8 hours is spent in the digital environment. And during this digital influence, there is a exposure to the food marketing. So we know that our food marketing exposes to ultra processed food, and marketing for the ultra processed food is so extensive that it reaches almost to each and everyone, not only in the digital environment, but also in our surroundings and the physical environment as well. This digital environments, engagement with the digital environments promotes sedentary screen behavior. So we are having this sedentary screen behavior, and during this sedentary screen behavior, the physical activity diminishes. Then the social media influence. So a lot of social media platforms are available, and children, they are spending a lot of time on these social media. And now there are many regulations all across the world where the children are limited to use social media platform before a certain age. Then there is another platform, that is the gaming, and the gaming can be very addictive, and a lot of children, they are addicted to the games. And I think this is a common behavior which we have seen whenever a child, even of 2-3 year age, if he or she cries, then the parents will immediately hand over a electronic gadget to them, and they immediately stop crying, and they start watching content on the screen. So, and later on the life, the gaming pattern and everything is happening. But can we do something? So the digital platform, they also offer opportunities for the digital health education, which is, I think, now integral part. We are also doing this webinar, which is a digital education platform only. Behavioral nudges are very, very important. So I think digital platforms can push some good behavioral nudges. Like, for example, if you are being inactive for some time, probably if you are using a wearable device or gadget, it can give you a nudge that you are sitting for a long time, you are not blinking for such a long time. Health applications many of them are available, and I think certified and valid applications can be promoted and used as well. And gamified physical activity, I think that if the game has to happen, it has to happen in the field. So gamified physical activity is something very, very important. So the challenge is shaping healthy digital ecosystem. So it is not the digital environment which is a challenge, but somehow I think the digital influence, which is more towards the negative side, is more aggressive, and the digital influence towards the healthy adoption of the digital environment is less. So I think we need to shape that system. Then comes the role of the families in the communities. And we know that the prevention cannot happen in silos. It requires a engagement of the entire ecosystem. And for example, if we talk about the family, so we have to look at the family dietary habits, which is a shared healthy meal. So if a family is adopting a healthy meal, then most of the time the children, they are also likely to acquire healthy meal habits. If everyone in the family is eating ultra processed food, or the food pattern is not that healthy, then the children, they are also likely to acquire the same habits. Parental modeling, sometimes the parents, they can also act as a active role model. So telling your child that you do physical activity, stay active, engage in sports. So I think we have to lead by example. So if the parents are also encouraged to do physical activity, the children, they understand the importance of this very important behavior. Then if you look at the community, then as a community infrastructure, like do we have access to the parks and the facilities to walk, to play, to exercise? This is again very, very important. So here comes the role of the community, and it is important to have such places and such safe places where children can play, children can engage in physical activities. Access to healthy food like fresh produce, and the availability to the fresh produce is again very, very important. And the safe spaces for the physical activity, as we mentioned, so secure environment for play. So community programs, they can improve long-term behavioral outcomes, and to engage more and more physical activity, community participation, I think this is very, very important. So what are the opportunity ahead? So if you look at the opportunities ahead, so preventing obesity early refers to, if we can do that, we can reduce the burden of the diabetes. We can reduce the burden of the cardiovascular diseases. And ultimately, this can bring down the cost of the healthcare, and this can lower the healthcare cost. And healthier societies leading to more healthier societies, more productive societies. And the goal should be a healthier metabolic future for the next generation. If you look at the policy and the system level action, so I would suggest that individual education should move to regulation of the food marketing to children. This is something which is very, very important. So it should be regulated very strictly by the governments. Taxes on the sugar sweetened beverages, this is a matter of debate, but many of the states, they're adopting this policy, and this is called sugar tax. Healthy school food policies, guidelines are also there, always there from the WHO and the leading World Health Organizations and all. But important is to get them implemented and see that they are implemented, and the parents and the children, they can take a lead and ensure that their environment in the school is healthy, is adopting good healthy school policy, food policies. Urban planning supporting physical activity. I think you say that go out and play, go out and run. But if you don't have safe places to do so, then it discourages people to do physical activity. Digital marketing regulations are again very, very important. So as a system has to think that how to regulate this and how to so, and prevention requires multi-sector collaboration. So it requires involvement of the law agencies, the healthcare professionals, educators, policymakers, governments, and pharma industries, and everyone has to come together for this multi-sector collaboration to provide policy and system level action. So early life prevention framework should address maternal health, provide support for the breastfeeding. Early nutrition is very, very important. Schools, they should focus on health education. Physical activity should be promoted. Healthy meals are very, very important. And digital behavior should be monitored, and digital behavior should be directed more towards the positive and healthy digital engagement. And regulation of unhealthy marketing is very, very important. And digital health should be promoted. So my take-home message is that if we want to reverse the obesity epidemic, prevention must begin before obesity begins. So early life interventions, school, digital environments can reshape the future health, and early life interventions and digital environments are the three critical pillars of the prevention. So with this, I would like to thank all the organizers, and again mention that it is very, very important that the prevention should be addressed early in the upstream, and the school offers us the best of the platform to do so. So with this, I would like to stop sharing my screen, and if there are any questions, I would be happy to take them.
Yes, thank you very much, Dr. Gupta. Very interesting talk. Thank you. I think we've got two questions here. You mentioned that obese children are 5 times more likely to stay obese as adults. At what age is an intervention most effective to prevent this long-term risk?
So I think this is a question, and if you look at my presentation, it is difficult to put a number to this, because we are a child learns so much from the environment. And I think it is right from the beginning, and we have talked about the prenatal environment also, that how does the maternal health during the pregnancy shapes the future risk. So it becomes right from the early nutrition in the early days. And I may not be able to put a number, but from different studies and the behavior patterns, a child with up to the age of 5 learns very fast. So if you provide a very, very positive environment and positive feedback and positive, healthy environment and healthy feeding habits, and I see a lot of people now. I see many parents coming to me, and they tell me that they have not shown a single screen to their child ever since for the last 2-3 years. So a newborn child, the new generation of the parents, they are aware, and they are not exposing their child even to the screens. And so sometimes they come and they say that they don't want their child even to look at the TV. So I don't know how they are doing it. So I think interventions should start as early as possible. And it is to be guided by our own environment. And I think the parents, teachers, and the policymakers, everyone has to take this responsibility.
Thank you. Okay. Next question is about education. Besides individual education, which systemic change do you think is most urgent right now? Sugar taxes or stricter regulation of food marketing to children?
See, if you impose sugar taxes, restricting marketing, definitely it is a discouragement for the industry to promote the ultra processed foods or unhealthy foods to the children. And I think it is very, very important. But children can learn more if they are positive interventions. And the positive interventions, for example, if there is a peer group, they learn very fast in the peer group. So they learn very fast in the groups. So group sports, group education, and group sessions, they can all help. So I think we cannot say that this one particular approach will solve each and every problem. So I think every step has some importance. So decreasing some of the aggressive marketing will help. Increasing the positive behavior adoption of the digital platform will help. At the same time, peer-to-peer education and the peer-to-peer networking is very, very important, where people they learn and adopt physical activity much earlier in the life.
All right. Okay. Thank you very much, Dr. Gupta.
Thank you, Mr. Ismail. Thank you so much, Professor Ismail.
Okay. I think we go on to the last speaker now, Dr. Satha, Assistant Professor of Medicine and founding president of the Cambodia Association of Diabetes and Endocrine Technology. Dr. Satha trained in internal medicine at the University of Health Sciences, Phnom Penh, and completed endocrinology training at the University of Strasbourg in France. He previously served as chief of the internal medicine unit at Calmette Hospital and has played a pioneering role in digital diabetes care in Cambodia, developing the Carnedia app and the Virtual Diabetes Clinic app. He's a fellow of the American College of Endocrinology and a senior fellow of International Diabetes Federation. Dr. Satha.
Thank you very much. It is a great pleasure joining this wonderful webinar and allow me to share the experience.
Yes.
Okay, thank you once again for this wonderful webinar. Let me share some situations and some lessons about Cambodia. Cambodia is a small country in Southeast Asia, and it used to be in Southeast Asia. And the problem is before we face malnutrition, but now at the same time, some region in the country face the problem of obesity, overweight and obesity. The Cambodian diet is changing from traditional diet rich in starch and fiber to the consumption of fatty animal sources food, refined carbohydrate and ultra processed food. This growing consumption of sugar, sweet beverage and energy drink high in sugar, fat and salt has become a major concern. According to our last step survey in 2023, we observed that the consumption of fruit and vegetable is not enough, and there is a high consumption of salty food, more than nearly twice the WHO recommendation to limit salt intake to less than 5 grams of salt per day. The consumption of sugar and sweetened drinks almost increased among all age group, young people, adults, both in men and women. It is observed also in the step survey result, the physical activity. Most of Cambodian adults are meeting the recommendation of 150 minutes of moderate to intensive activity per week, but still only 9.3% of adults having insufficient physical activity. People smoke, in particular among men in rural area, and there are a lot of harmful use of alcohol. Or nearly half of adults aged between 18 to 69 report that they have engaged in heavy episode drinking during the past 30 days, according to the result of our step survey. That's why the prevalence of hypertension and high cholesterol is increasing among our adult population. overweight in the STEP survey supported by WHO, they show that nearly 20% of Cambodian adult have obesity. Having said that, with the support of WHO, the cut point is 25. But if we look at the Asia Pacific, the prevalence of overweight and obesity would be higher if we choose the cutoff point to 23. However, like other Asian population, we don't have to be very, very obese to have higher risk of diabetes, 23. That's why obesity in Cambodia is rising rapidly, not simply because of overconsumption, but from a combination of a rapid urbanization, the growing presence of ultra-processed food, low nutrition literacy, physical inactivity, limited screening, and inconsistent definition of obesity. We follow WHO or Asia Pacific, so it's still a debate between BMI 23 or BMI 25. Facing those challenges, the government are putting the National Strategic Plan 2022 to 2023, trying to reduce the overall mortality, behavioral risk factor, try to reduce the prevalence of hypertension, diabetes, obesity, and management of severe risk, diabetes, and cervical cancer, and try to give more opportunity, health coverage across the nation. This is the all the stakeholders that help the government try to achieve those goals. We have health center staff, we have provincial hospital, and then the national hospital, dealing with NGOs, societies, and also from international agency like UNICEF, WHO, etc. The Ministry of Health is publishing very soon the first ever recommendation guideline about nutrition, trying to educate the people knowing about their diet. It is the first ever nutrition guideline produced by the MOH, the Ministry of Health. The Ministry of Health also conducted a lot of campaigns: less sugar, less salt, less fat. In the ringtone, when we call someone on the phone, the ringtone say less sugar, less salt, less fat. And social media also in the health promotion department of the Ministry of Health. Since 1997, the government tried to increase the sugar tax 5%, 10%, 15%. And also this lesson from our situation, we have to act early before obesity prevalence explode, address undernutrition at the same time obesity together, integrate metabolic health into national NCD strategy, and focus on prevention and early detection. With that, thank you very much for your attention.
Okay, thank you very much, Dr. Satha. I think we have a question here.
Yes.
The Asia Pacific BMI threshold for obesity 23 is lower than WHO standard 25. Are we currently underestimating the true scale of the metabolic crisis?
Yes, but because we follow the WHO during our STEP survey, that's why in the official publication result of the STEP survey is 25. But if we reduce the cut point and follow Asia Pacific, I believe that the obesity prevalence is more than 20%. Yeah.
Okay. So there are no more questions. Okay. So I would like to thank you very much, Dr. Satha, for giving an interesting talk. We never thought that obesity would be a problem in Cambodia, but apparently it is even now. Thank you very much, Dr. Satha.
Thank you once again.
On behalf of the National Cancer Society Malaysia and BUZUD, thank you for joining our World Obesity Day seminar. We extend our deepest gratitude to our speakers for their invaluable insights into transforming metabolic health. We also thank you for engagement and thoughtful questions throughout the afternoon. So with that, I would like to invite Mr. Frankie Pham to deliver the closing note.
Ikram, thank you very much for chairing and moderating, and also to our partners, especially the National Cancer Society of Malaysia, our esteemed speakers. On behalf of BUZUD, we wish to thank you. I think it was a very eye-opening, and I think the topic was really something for us to take home and do more. That on behalf of Mr. Frankie and the team, we wish to thank everybody for attending this. So, Mr. Prof. Ikram, back to you.
Okay, thank you very much. So with that, we end this session. And again, thank you very much for all who joined us for this afternoon session of wonderful science. And I hope we'll benefit from this. And interestingly, we should start from the cradle, from the utero, to prevent this current epidemic of obesity. With that, thank you very much.